collective noun for menopausal women would be? What do we think? A hot flush of women? A hot take of women? I don't know what you think about that. And it's so great that Sarah's written this book. It's so accessible and it's really helpful thinking about the challenges, the pressures, the opportunities that come at this point in a woman's life. Look, I haven't found very many Christian resources out there, so I do warmly commend it to you. So look, my task in these next 20 minutes or so is to give you an overview of the menopause from a medical perspective. So as I said, I've worked in the same practice for 20 years in South London, and I'm sure it won't surprise you to know that most days I'm at work, I'll have a conversation with somebody about the menopause. I'm actually convinced that they look at the practice profile pictures online and think, oh, I might talk to her, she might have some idea about what I'm talking about. And look, it's actually a very satisfying consultation because I really feel like my patients are helped. I also teach medical students, and look, menopause was not on the curriculum when I was at medical school, but it is now, so it is out there, we're talking about it, we're learning about it, it's all much better than it was. Look, I'm no expert on menopause, I'm just a GP, neither am I a seasoned public speaker, but I have thought a bit about it. I don't want to champion it all, but I want to raise awareness, I want to give you some information. I'm also aware that this topic might cause some painful and difficult issues as we discuss what it's to be a woman, what it is to be a mother, the changes that are going on in our bodies. So can I preemptively ask your forgiveness if I'm insensitive or clumsy in my handling of any of these issues? Now look, there's a range of age in the room. You may be out the other side of menopause, or you may be having a hot flush as you sit there. And maybe you're here to equip yourself with some biblical thinking, some medical information before it all begins. You may have had a great experience with a medical professional, or maybe you haven't. You might be breezing through and wondering what all the fuss is about, or you might be suffering physical discomfort, mental angst, spiritual questioning, and feeling disorientated and isolated. And look, you may know lots of this stuff, or you may know nothing, but I hope, whatever your personal circumstances, I hope you can take something from what I have to say, either for yourself or to help a friend who might be going through the menopause. 75% of women report symptoms. On average, they last for 7 years, but for a third of women, it may be longer than that. In one study, 1 out of 2 women stated that menopause caused a negative impact on their home life, 1 out of 2 a negative impact on their sex life, 4 out of 10 women said it had a negative impact on their work life, and 3 out of 10 that it had a negative impact on their social life. Balance that with an article published in the BMJ, British Medical Journal, in 2022, entitled Normalising Menopause, Raising Awareness of Overdiagnosis and Overtreatment. In it, the researchers point to data suggesting the experience of menopause differs widely between countries and cultures. Expectations and experiences are influenced by personal, family, and socio-cultural factors. For example, African-American women experience menopause earlier than other groups and may have more troubling vasomotor symptoms, the hot flushes we've been talking about. Asian women in Korea and Vietnam report body and joint pains as the most troubling symptoms. And only 5% of Indonesian women suffer hot flushes. The article also states that negative attitudes towards menopause may increase the severity of the symptoms. So there are migration studies that show women may experience troubling symptoms when moving to a country with a negative view of menopause when they wouldn't have done so in their own country. I found that all quite interesting. And another thing to point out is, of course, life expectancy is getting longer all of the time. Just think about it. Women will now live a third or even half of their lives after the menopause. And so we should be thinking about the all-round health of women in these later years of life. So let me define where I'm going with this, outline where we're going with this. So some definitions to start with, then some symptoms. In a previous talk I gave, I did wonder whether I gave you all a card and we had a kind of menopause symptom bingo and, see if anybody has full house. I'm not going to do that, but you get the gist. Then we'll talk a bit about diagnosis. And then we'll look at some treatment options. So looking at different lifestyle and non-hormonal options, but also about HRT, looking at the benefits versus the risks, looking at the side effects. Okay, so some definitions. So, the menopause. When you get older, your ovaries stop producing the hormones estrogen and progesterone, and your monthly cycle of egg production winds down, and eventually your periods stop. Now, you don't know it's your last period until you've not had one for a whole 12 months. So the menopause is your last period. The perimenopause is a time around that, before and after, that can take several years, where the functioning of the ovaries, the hormone production is fluctuating. This is when the women will start to experience irregular periods, hot flushes, and all manner of other things that we'll come on to. The average age for menopause is 51, but there's a range. And certainly anybody experiencing any of those symptoms over the age of 45, we're starting to think, is this menopause? Other terms you may hear, so early menopause, that's when the symptoms occur between the age of 40 and 45, or premature menopause, or the term we more routinely use now is primary ovarian insufficiency, and that's when the symptoms start before the age of 40. There's also surgical menopause. That's when the ovaries have been removed during surgery, or if there's been radiotherapy to the pelvis for cancer, for any reason like that. Okay, so there's the diagnoses. The definitions. Symptoms, here we go. So, irregular periods, so a change in the cycle. It might be shorter, it might be longer. Oftentimes it's heavier, though not always. Vasomotor symptoms, so hot flashes, night sweats. Or it could just be a general sense of hotness. And spicy food and alcohol can be triggers for those. There can be sleeplessness, which might be associated with those hot flushes, but just also general sleep disruption that's not at all related. Joint pains, headache, fatigue, dryness of skin and hair, dizziness, palpitations. And then there's the cognitive issues, so poor concentration, a particular favourite of mine, word-finding difficulty, trouble with multitasking, effects on memory. Often women say to me, I'm really worried that I'm getting dementia, I'm really worried that there's a big problem here, and oftentimes it's not that, it is menopause. And then mood effects, low mood, anxiety, irritability, short fuse, we all know about that one, mood swings, loss of confidence. And then urogenital issues. I did wonder if that word had ever been said out loud in this building before. Urogenital issues. So, irritation, discomfort, dryness, itching, increase in urinary frequency, which means going to the loo more often, and then urgency of frequency, having to rush when you need to go. There can be problems of sexual dysfunction, so the dryness can cause pain, and along with the reduction in libido, poor mood, low confidence, they can really have an impact on sexual functioning. So all of these things are leading to a general reduction in the quality of your life. Okay? So moving on, diagnosis. Again, diagnosis makes it sound like a disease, doesn't it? It's not a disease. It's a naturally occurring change in everyone's life. I was reflecting on that. We don't often diagnose puberty, so I wonder whether we should change our use of the term. Anyway, we do talk about diagnosing menopause. Look, not everyone will want or need to speak to their GP about their symptoms. Awareness and public information is much more widely readily than it ever was, and I'll signpost you to some helpful resources at the end. And women may feel that they've read enough and are able to manage the symptoms they have without any medical input. Look, I'm all for that. And if they're getting good evidence-based information and making informed choices, that's great. However, lots of women do like to talk to their GP. Menopause is primarily and usually a clinical diagnosis. What that means is me as the doctor is looking at the woman in front of me, hearing about her symptoms and putting them all into a context. The difficulty is that the symptoms are so broad-ranging and non-specific that sometimes deciding menopause is the cause is quite tricky. And for lots of women, that conversation is really, really important. And often I feel one appointment is not really enough for the woman to tell me her story in sufficient depth or for me to assess what's going on. So we often have another bite of the cherry. Let's spend a bit more time, go away and read about it, come back. Let me say at this point, you may well have heard of some other hormones. So LH, which is luteinizing hormone, and FSH, which is follicle-stimulating hormone. These are hormones that are produced in the pituitary gland in your head, and they regulate the progesterone and the estrogen being produced by your ovaries. Now, as you approach the menopause, the estrogen level drops, and because all of these hormones are in a negative feedback cycle, the FSH and the LH will go up. However, those levels are fluctuating all of the time, so you can't use the LH and the FSH reliably to diagnose menopause or perimenopause. And the national guidelines do not advocate measuring them to make the diagnosis. It's a clinical diagnosis. It's that conversation that you're having. That said, there would be a few instances where it is helpful, and usually that would be in women where you're thinking of early menopause or primary ovarian insufficiency. So if they're younger, that would be part of the workup to decide if that's what's going on. So in the discussion with the doctor, she or he will be formulating what's called a differential diagnosis. And that's essentially, what could this be? What do I need to rule out? What else is going on? And there are other conditions that may be going on. So endocrine issues, such as an underactive thyroid. Hot flushes might be caused by an infective condition, by anxiety, by a panic disorder. And in rare cases, night sweats might be caused by some cancers. Joint pains might be a rheumatological condition. There might be irregular vaginal bleeding. That might be perimenopause, but there are other conditions that need consideration. So polyps or fibroids in the uterus, other vaginal issues. And that's why it's so important to have an individualized, careful conversation with your doctor. It will include discussion about your symptoms, your period history, your family history, contraception, smear history, other conditions past and present, any medications you're on, whether you smoke, whether you drink alcohol, and also then what impact is this having on your functioning, on your lifestyle. Your doctor might then suggest a pelvic examination, though usually not. He or she might want to know your blood pressure, your height, your weight. They might also advise some blood tests, but usually that's to rule out some of those other causes. And then when you've had that discussion, then you'll move on to talk together about your management options. So first on that, so lifestyle, and Sarah's touched on lots of these before. There are lifestyle and behavioural factors that can help. So for hot flushes, losing weight, doing exercise, regulating the temperature in your bedroom, wearing lighter clothes or layers so that you can take them off as needed, reduction of spicy foods, the caffeine, the alcohol. For poor sleep, again, doing more exercise, but don't do it too late in the day because that can sort of stimulate and impact going to sleep. And having a routine and a regular bedtime can be really helpful. Mood and cognitive issues, again, exercise, more sleep can help, and then just general stress reduction measures. And then for general health at this time of life, it's what you'd expect. Stopping smoking, weight monitoring, increasing exercise, especially, as we've mentioned, the weight-bearing exercise for your bone health. So weight-bearing, things like walking, running, weight training, things like cycling and swimming are not weight-bearing. So they're good for your cardiovascular health, for your lungs. They're not going to help your bones. Okay, so all of that's got to be put in the mix. A well-balanced diet for your gut health, ensuring strong social and emotional connections for your mental well-being, and then taking care of your spiritual health, some of the things that Sarah's been talking about already. Then there are non-hormonal treatments. So for hot flushes, drugs such as citalopram and fluoxetine, which are more commonly used as antidepressants, they can be shown to be helpful in some women. And they can also be used for sort of menopause-related mood disorders, where there's a sort of crossover of the two. Cognitive behavioural therapy for CBT, that's a type of talking therapy. There are a couple of other drugs that can be used for some symptoms, so something called clonidine and gabapentin. And then for the urogenital issues, there are non-hormonal moisturisers and lubricants that can be used to ease discomfort and aid intercourse. Over-the-counter preparations, so there are some things such as isoflavones, black cohosh that you might have heard of. Now, these type of products have not been put through rigorous trials. We don't know for any certainty their effects. We don't know for any certainty their side effects. Often they will interact with other things that you may be taking from your doctor or over the counter. So they're actually not recommended by NICE and the general guidelines. They also might have some small amounts of phytoestrogens in them. So if you can't take traditional HRT because you're shouldn't be having any estrogen, you might inadvertently be having some small amounts of estrogen in some of these products. So, as I say, not recommended. Okay, so HRT. So far and away the best treatment for menopause is HRT, hormone replacement therapy. I'm going to give you a very simple overview. Look, it's not as complicated as you think it might be. So in essence, it's restoring the estrogen that your body is now lacking. It comes in the form of tablets, patches, gels, or a spray. The topical forms, topical means it's absorbed through your skin, have been shown to have a lower incidence of side effects, and that's almost exclusively what's now prescribed. If you still have a uterus, you will also need progesterone. And this is because the estrogen on its own can cause an overgrowth in the lining of the womb that can lead to the cells becoming abnormal. Now that can come the progesterone can come either in a patch or in a tablet or in a progesterone-containing coil like the Mirena. I just, at this point, want to have a quick aside about the Mirena. So its method of action is not entirely well understood. There are thought to be several ways that it works in different women at different times of the cycle. But one of them may well be to stop an already fertilized egg from implanting in the womb. So that needs to be a consideration if you're still having periods and you need it for contraception as well as HRT. Okay. So if you have a uterus, you're on estrogen and progesterone, and there's another consideration around the progesterone. So if it has been over a year since you last had a period, you can go on a continual regime. So that's estrogen and progesterone every day. However, if you're within that 12 months of having had a period, we usually put you on a cyclical regime. So that's taking progesterone for a set number of days each month. And then what will happen is when you stop your progesterone, you usually have a bleed. Now, the reason for that is you've still got some residual ovarian activity of your own. And if you go on the continual regime, you'll just bleed all over the place. So if you take your few days of progesterone and have a set bleed after that, you can just manage when it's going to happen a bit more easily. And then 2 or 3 years down the line, we may try you on the continual regime and see how you get on. Okay. Another medication that your GP can prescribe is vaginal estrogen. So this is in the form of pessaries or creams or tablets or a vaginal ring. Now, this is really effective in treating those urogenital symptoms that I mentioned. It's very safe and it can be used long term. I've even heard it suggested that perhaps every woman gets sent some vaginal estrogen in the post on their 45th birthday because it's so safe. Don't know about that. Okay, so there can be side effects. Estrogen can cause bloating and breast tenderness, nausea, headaches, reflux symptoms. Often those things will settle when you get used to being on it. And then the different progesterones can cause similar symptoms, but in addition to that, there can be sort of mood swings, low moods, acne, a bit of PMS, those kind of things. And when HRT started, there can be some unscheduled bleeding for the first few months, but if it persists or it's particularly heavy, then that's something that should be flagged with the doctor. And then once you've been prescribed it, you'll have a review at 3 months and then yearly, and the doctor will go over your lifestyle advice, check if your HRT seems to be working, whether the dose is right, whether there are side effects, check that you're up to date with breast and cervical screening, and that you haven't had any unusual vaginal bleeding. As far as the length of time that you can take HRT, the guidelines state that as long as the benefits of symptom control and an increase in quality of life outweigh the risks, there is no arbitrary limit. That said, after the age of 60, the rule of thumb seems to be to ensure that you're using the lowest dose of the estrogen, and then just to consider stopping. Make sure that's a conversation you're having with the woman. Women taking HRT for vasomotor symptoms are on it for an average of between 2 and 5 years. And then when the HRT is stopped, we tend to taper it off because there can be some sort of rebound hot flushes that you have. So if you do it more slowly, you come off it more successfully. And vaginal estrogen, as I said, is safe to use in the long term. And then lastly, on the hormones, testosterone. This is more contentious. It's used in the treatment of low libido when HRT hasn't helped. Because of current licensing in this country, it's much more commonly initiated in specialist clinics, though it is becoming more wide practice to be started in GP if the GP feels that they're functioning within their own experience and expertise. Risks and benefits. You may have heard some of these things. Let you hear me say, not all women can take HRT. Not everyone can take HRT. It's not safe for everyone. And that's why I said a careful, individualized discussion with your GP is what's needed. The risk that you, I'm sure, will have heard about is breast cancer. So if you have a personal history of breast cancer, either past or current, you cannot take HRT. Excitingly, there's a new drug on the horizon that may help breast cancer patients. It's called ospemifene. It's still in research, and there is reason to be hopeful that it might be helpful to people that can't take estrogens. In other women, taking HRT causes a small increase of a small risk. And often, even with a family history of breast cancer, HRT can be considered. HRT does not increase the overall risk of dying of breast cancer. Let me point you to, if you were to Google the British Menopause Society, there's as I say, there's a link in the back of your handout. If you were to Google breast cancer HRT infographic, it's got a really lovely, pictorially presented display of the increased risks of various things for being on HRT, having breast cancer. Let me just summarise it, if I may, briefly. So it shows in the UK general population, per 1,000 women, between the age of 50 and 59, 23 of them will get breast cancer, just anyway. So 23 per 1,000 between 50 and 59. On combined HRT, there would be an additional 4 cases. Listen to this, though. Other factors have a bigger effect. So in a woman drinking 2 units of alcohol a day, there are 5 additional cases. So your increased risk of breast cancer from HRT is less than drinking 2 units of alcohol a day. And then this one, in women who have a BMI over 30, so overweight or obese women, there are an additional 24 cases. Okay? So the message about the increase of breast cancer for being on HRT is real, but often not presented in a balanced and very informative way. Okay, but have a look at that infographic, it is helpful. Okay, HRT cannot be prescribed in known or suspected estrogen-dependent cancers, obviously, or in acute liver disease, or somebody that's had a recent heart attack or angina, and with some clotting disorders. There are other conditions where it should be considered a bit more carefully, but it usually doesn't preclude the use of HRT, such things like venothromboembolism, so that means clots in your legs or your lungs, or migraines. So further discussion about those. Now then, benefits. So, foremostly, a reduction in symptoms, and with that, a general improvement in the quality of life. Most women I talk to at that 3-month point are absolutely delighted with the benefits, and they feel like themselves once more. In addition, there are the proven benefits, the protection of your bones, making it less likely that you break a bone if you fall, and less likely to develop osteoporosis. There are also longer-term benefits to your cardiovascular health, so heart and blood vessels. There's limited evidence that it might increase your muscle mass and strength, and there's help with the urogenital symptoms that I mentioned. And there's some evidence that it might help cognitively in some women in terms of a dementia risk, but we're kind of waiting for much more robust evidence on that. And then a few important final things to say. So you also need to consider contraception. You may not be releasing an egg very often, but as you know, it takes 1 egg and 1 sperm. So unless you're happy to have an unexpected gift in your late 40s or 50s, you do need to address that. And there will be different options depending on your age and when you last had a period. So if you are over 50, the advice is to use contraception for 1 year after your last period. If you're under 50, that's 2 years. Okay? And then if you normally pay for your prescriptions, this is a bit of a win. There was recent pressure brought to bear in Parliament. So if you pay for your prescriptions, there is now a prepayment certificate for prescription charges for HRT. So you pay a one-off annual fee of £19.80, random, and then you don't need to pay any more for that year. So if you Google HRT prepayment certificate and complete the online form, that's really helpful. So look, I'm aware this has been a real whistle-stop tour of all things menopause. Please don't feel overwhelmed by it. There's lots and lots of good resources out there. Most GPs are knowledgeable and competent to manage menopause. And if not, they can refer you on to specialist menopause clinics if it's a particularly sort of tricky situation to navigate. So if you just look in the back of the resources that I've put there in the back of your handout, obviously these are not Christian resources, so I'm not saying it's all there. You've got to read it with your Christian viewpoint. So I'm not recommending everything that they say, but they are helpful in terms of the science. So Menopause Matters, Rock My Menopause, the British Menopause Society, and Balance website, that's a new one with Louise Newsom. You might have seen her in the media or heard about her. She's pretty sensible. And they have an app where you can track your symptoms, and there's some good podcasts if you're somebody that prefers to listen to stuff rather than read it. There is one book I found called The Natural Menopause by Anne Henderson, who is a doctor, and it's a resource for women who want to take perhaps a more natural approach to the menopause, either by choice or because they can't take HRT. I wouldn't be able to recommend the first bit of it, all about herbal remedies, but the second bit, which is about particular exercises and nutrition and sort of mindfulness, things like that, might well have some helpful things in it. And I have got a copy. I'll leave it on the front here if anybody wants to come and just have a leaf.
I was inspired to write this book because a few years ago, menopause hit me. When that was first happening, there were a lot of books being published by celebrities. There were experts writing books about the menopause too, and there was discussion in Parliament. Everybody seemed to be interested in the menopause. But Christians weren't talking about it. So it started me wondering, well, what does the Bible say about the changes that women's bodies go through? How should we understand them? And is there any help that the gospel offers us? I hope that readers will put the book down after finishing it, excited about the opportunities that Jesus gives us in midlife and menopause, opportunities to serve and to change and to know him better.